Hello and welcome. Today we're diving into a rare and complex neurological disorder called Pantothenate Kinase-Associated Neurodegeneration, or PKN, formerly known as Hallervorden-Spatz disease. This condition affects the brain, leading to progressive movement difficulties and other debilitating symptoms. Join us as we unravel the intricacies of PKN, exploring its causes, effects, diagnosis, and management. At the heart of PKN lies a genetic mutation. This disease is primarily caused by mutations in the PAN2 gene. This gene provides instructions for making an enzyme called pantothenate kinase 2. This enzyme plays a crucial role in the metabolism of vitamin B5, also known as pantothenic acid. Pantothenic acid is vital for the production of coenzyme A, a molecule necessary for many biochemical reactions in the body, particularly those involving energy production and fatty acid metabolism. PKN is typically inherited in an autosomal recessive pattern, meaning that an affected individual must inherit 2 copies of the mutated PAN2 gene, one from each parent. If both parents are carriers of the mutation, there is a 25% chance with each pregnancy that the child will inherit the condition, a 50% chance that the child will be a carrier, and a 25% chance that the child will inherit 2 normal copies of the gene. The absence or dysfunction of pantothenate kinase 2 disrupts the normal metabolism of pantothenic acid and coenzyme A production. This disruption leads to an accumulation of certain substances, particularly iron, in specific areas of the brain, most notably the globus pallidus and substantia nigra. These regions are critical for controlling movement. The iron buildup is thought to generate harmful free radicals, which damage and destroy neurons. Over time, this neurodegeneration leads to the progressive motor and cognitive impairments characteristic of PKN. The Y of the tiger sign, seen on MRI scans, is a hallmark feature, representing the iron accumulation and surrounding changes in the globus pallidus. PKN is a very rare disorder. Its exact prevalence is difficult to determine, but it is estimated to affect approximately 1 to 3 individuals per million worldwide. Because it is a genetic disorder, it can occur in any population, but there may be founder effects in certain regions where a specific PANK2 mutation is more common. The condition typically presents in childhood, although later onset forms have been described. It affects both males and females equally. The symptoms of PKN are progressive and can vary significantly from person to person. Early symptoms often include difficulties with movement, such as dystonia, characterized by involuntary muscle contractions and twisting movements. Rigidity, or stiffness, can also be present. Other common symptoms include choreothetosis, a combination jerky and writhing movements, spasticity, or increased muscle tone, and Parkinsonism, which can manifest as tremors, slow movements, and postural instability. Speech difficulties, such as dysarthria, and swallowing problems, or dysphagia, are also frequently observed. In addition to motor symptoms, individuals with PKN may experience cognitive decline, behavioral problems, seizures, and vision problems, such as retinal degeneration or optic atrophy. Diagnosis of PKN involves a combination of clinical evaluation, neuroimaging, and genetic testing. A thorough neurological examination is crucial to assess the individual's motor and cognitive functions. Magnetic resonance imaging, or MRI, of the brain is a key diagnostic tool. The characteristic Y of the tiger sign observed on MRI is highly suggestive of PKN. Genetic testing to identify mutations in the PANK2 gene confirm the diagnosis. Other tests, such as blood tests to evaluate iron levels and other metabolic markers, may also be performed to rule out other conditions. While the most common form of PKN is caused by mutations in the PANK2 gene, leading to classic PKN, there are atypical forms associated with other genes in the NBI family. These atypical forms may present with different symptoms or a later onset. Some examples include PL2G6-associated neurodegeneration, MPN's mitochondria-associated protein-associated neurodegeneration, and others. Proper genetic testing can help differentiate between these various forms of NBIA and refine the diagnosis. Currently, there is no cure for PKN. Treatment focuses on managing the symptoms and improving the individual's quality of life. Medications, such as baclofen, trihexyphenidyl, and botulinum toxin injections, may be used to alleviate dystonia, rigidity, and spasticity. Physical therapy and occupational therapy can help maintain mobility and independence. Speech therapy can address speech and swallowing difficulties. Deep brain stimulation, or DBS, is a surgical procedure that involves implanting electrodes in the brain to modulate neuronal activity, and has shown promise in reducing motor symptoms in some individuals with PKN. Nutritional support, including a gastrostomy tube for feeding, may be necessary if swallowing becomes severely impaired. Iron chelation therapy to reduce iron buildup in the brain has been investigated, but its effectiveness remains uncertain. As a genetic disorder, there is currently no way to prevent the condition itself. However, genetic counseling and testing are available for individuals with a family history of PKN or other neurodegenerative disorders. Carrier testing can identify individuals who carry a PANK2 mutation and are at risk of having a child with PKN. Prenatal testing, such as amniocentesis or chorionic villus sampling, can be performed during pregnancy to determine if the fetus has inherited the condition. The prognosis for individuals with PKN varies depending on the age of onset and the severity of the symptoms. Early onset PKN typically progresses more rapidly than later onset forms. The condition is progressive, and most individuals will experience a gradual decline in motor and cognitive function over time. Life expectancy is often reduced, but with appropriate medical care and supportive therapies, individuals with PKN can live into adulthood. Recent research has focused on developing new therapies for PKN, including gene therapy and enzyme replacement therapy, which aim to correct the underlying genetic defect or replace the deficient enzyme. These approaches are still in the early stages of development, but they hold promise for potentially slowing or even reversing the progression of the disease in the future.